Hi, my name is Angie Caton, and I'm here to present Designing a Referral Process in a Large Health Adult System to Address the Needs of Adolescents and Young Adult Patients with Cancer. So the introduction is that we all know that patients with cancer have unmet needs that can impair their medical care and treatment uptake. And we usually address those issues by using a distress scale, usually the visual analog scale from 0 to 10, and 21 questions that talk about psychosocial distress, physical impairment, speech, functionality, and other practical concerns. And these responses are usually documented in our EMR by staff on the phone or in person. But sometimes these categories might not adequately capture the particular concerns that adolescents and young adults with cancer may have because they're in their early stages of family planning, careers, education, etc. Furthermore, the results of those tools currently utilized don't trigger referrals all the time for the appropriate resources. Ideally, an automated approach would ensure that a referral process for self-identified needs occurs consistently. And these would approach the young adult in a holistic manner. So we designed a study to help describe the development of a referral system that uses validated scales for assessing AYA cancer survivor needs and then referring them back to the appropriate resources in palliative care, chaplaincy, social work within a large health system, and to evaluate the implementation and effectiveness of the screening and referral process from a provider and a patient perspective. We used the theoretical model, the lifespan theory of control. And what it does is that it helped to guide our work and plan the work of the research team. It suggests that threats or actual losses in the ability to control important outcomes such as performing self-care may activate individuals to use strategies to buffer threats and losses. Specifically, the proactive use of positive strategies, interventions, and resources may help AYAs reduce the current and future negative physical and psychosocial health issues associated with cancer treatment. We also utilized the NCCN, the National Comprehensive Cancer Network, Distress Management Guidelines, and Adolescent Young Adult Oncology Guidelines to categorize 5 domains for AYA survivorship to help guide and plan the work of the study. Some of the research questions we had, and there's like 6 of them with some A and B's added to one of them. What are the most common resources needed by AYA cancer patients? To what extent can the referral system be implemented in a large health system to automate a targeted response? What stakeholders are needed? What are some of the barriers? And to what extent do AYA cancer patients respond to automated questionnaires in the 5 domains? What are the barriers to responding to these automated questions? And how well do those resources meet the perceived needs of the AYA cancer patients? To what extent does the referral system affect their sense of control for the AYA patient to manage their treatment, relationships, and work-life responsibilities? The procedures as most commonly used for most all studies, we got IRB approval. We also presented to our Professional Nursing Governance Council, Research Evidence-Based Practice Council. We obtained patients through the oncology registry pathology uploads, and I contacted them through my chart messaging. I also consented them in person at agreed upon office or clinic time. We notified the team members after the consent was obtained, sent the message with the distress scale to the study participant, messaged the team members, updated the team sites, identified study participant in the EMR, informed the care team of enrollment in the study through my chart messaging. Study participants were contacted by their preferred method of communication to conduct the post-survey interview questions. Interviews were recorded when given permission, and they were asked about their experience, satisfaction, sense of control when using the referral system. Also, we conducted interviews with the clinical and hospital staff participating in the study. Research team members conducted the interviews of the chaplains social worker, and nurse navigators. Interviews were recorded with permission, and the clinical and hospital staff involved in the referral process were interviewed about their experiences that positively influenced or acted as barriers to the implementation of the referral system. So here's the design. It's an observational design to observe the creation and implementation of a patient referral system using quantitative and qualitative measures to the extent and effectiveness in serving the AYA cancer populations. So we included patients 16 to 39 with a diagnosis of cancer of any kind between December 1st, 2022 and December 1st, 2023. We excluded patients that did not have MyChart accounts. The sample size was determined by the number of patients deemed eligible for the study and who consented to be in the study. Patients, like I mentioned before, were identified through an uptake as analytic cases by the oncology registry at our hospital and recruited when contacted by the primary investigator. Patients were consented by the primary investigator in person once identified. So the young adult needs were first assessed using the EPIC distress scale, and then based upon self-identified concerns, additional scales were used to assess the young adult automatically, sending referrals to team members through the EMR. So for my best example is that someone that was completing a distress scale said they have spiritual distress. They would automatically get the next scale under spiritual distress, the functional assessment of chronic illness therapy, or the FACET SP12, and then that would trigger a chaplain to receive that notification that they had completed that spiritual domain questionnaire. The same work with all the others. Personal relationship domain, those would go to the social worker. Survivorship domain, the social worker. Practical domain, the nurse navigator, and body image, the social worker. And as you can see, the different types of scales that we use for each one. Some of the demographic findings of the study. So identified 106 identified young people in a calendar year with a diagnosis of cancer. 23 were consented, and 20 actually participated in the study by answering the questionnaires. The median age was 33. The range was 18 to 39. The top occurring cancers in the identified AYAs were thyroid, breast, and testes. The study findings. The most needs identified, self-identified by the AYAs, came in the categories of social relationships, then practical concerns and spirituality, and then survivorship and spiritual care. Less common were the sexuality body image for females and the sexuality body image for males, with only 1 and 2 people identifying needs in those areas. The services utilized most were that of chaplains, the nurse navigators, and social workers. The gender of consented participants were mostly female. The race of consented AYAs were also Caucasian and Latino. Some of the other interview summary points that I have here is that 47 or 44% of the 106 did not respond to the MyChart messaging, and I tried 3 times over 90 days. 100% of the 20 that I interviewed had no barriers to responding to the automated questionnaires. They didn't think it was too long. They thought it was pertinent. 100% or all 20 identified that they felt a sense of control that had increased after participation in the spiritual and the social domains. 40% or 8 of them identified the need for personal support in the form of a support group, additional support, and those were mostly the breast and thyroid patients. 50% or 10 of them identified unresolved financial concerns and work-life responsibilities. So even though they had been helped with things, that they were still unresolved financial concerns. 15% or 3 identified unresolved survivorship concerns, and that was mostly surrounding treatment and symptom management issues. The stakeholder interviews were much more simpler, and there were a few barriers in receiving notification of the AYA participants or their scales, and we found that to be a user error, and more training was conducted. Some of the barriers. So, coordination of appointments for consenting. There were many no-shows, appointments, locations changed at the last minute. I haven't counted all those up, but there were quite a few. 5 were deceased before, out of the 106, 5 were deceased before I even made contact with them. Our pathologies, 3 were classified as malignant when they weren't. Unexpected number of 7 Spanish-speaking only AYAs. And I've been in this community for 22 years, and I expect a lot of our older adults maybe not to have had, or not to be fluent in English or understand English. Just did not expect that for my AYA patients. But with that said, I had the inability to consent 7 of them because I did not have the consents in Spanish or the referral questionnaires in Spanish. Lack of my chart or computer access, that was an exclusionary criteria, but I kept up with the reasons. 5 just didn't have it. 2 of my AYAs are incarcerated, in prison, not just jail, they were in prison, and 1 was in a mental health hold for a suicide attempt when she could not have any computer access. The references are listed there, and our team members are listed below that. Do you have any questions? Angie, ANGIE.CATON @NGHS.com. And thank you so much for listening to my study.